We're delighted to have you here tonight. We have an excellent presentation for you. Dr. Stephan Heckers, who I'll introduce in just a few minutes here, is such a friend to NAMI, and it never fails to provide us with information that is useful and timely. We wanted to welcome you, those that may not know NAMI. We are a peer-to-peer organization of people with lived experience and family members. That's kind of what makes us unique. We are the largest peer-to-peer mental health organization in the country. And the NAMI Davidson County is the capital city affiliate. We have a long-standing relationship with Vanderbilt Behavioral Health, one that we cherish and enjoy. And they are forever, once May comes back around. May 20th, 2023 will be our annual NAMI Walks Greater Nashville. And Vanderbilt is a regular and part of our foundation for that event. We do have a couple events I'd like you to be aware of. One is this Sunday. We will have our caregivers only group. It is in person. We are back in person with that group only at the Christ Church of Nashville. If you will go on our website, namidavidson.org/calendar, and take a look, you will see that caregivers support group listed there. Just you will do the same that you did for what you did tonight to get on. You click on the events and you can get on. And this is for caregivers only. We also have a tradition coming up that we share with Vanderbilt Behavioral Health, and it is our Dirty Santa annual holiday party. And we will be hosting that in person for the first time since 2019, but we're going to host it in person at our office, and more information will be forthcoming. It will be the 21st of December. That's all the information I have to share. I would like to introduce Tracy Glasgow, who is our host from Vanderbilt.
Hello, everybody. I'm excited to see this great turnout. I knew it would be a great turnout, as it always is. And just wanted to piggyback on what Robin said. We have a long-standing relationship with NAMI Davidson in our collaborations, and including the walks and education sessions and support groups. And we look forward to a long future of collaboration. And I'm excited about tonight. At our hospital, we have a wide array of services, including inpatient services for really ages child all the way up through geriatrics, and including some partial programs for adolescents and adults, as well as intensive outpatient programs for young adults, as well as co-occurring disorders. That's with substance abuse and co-occurring mental health diagnosis. So we really have a wide array of services at Vanderbilt Behavioral Health. And we're going to turn it over now to the person that you came to hear, Dr. Heckers.
All right. Thank you very much, Tracy. And so we have Dr. Stephan Heckers with us tonight. He's the James G. Brakemore Chair in the Department of Psychiatry and a professor of psychiatry and of radiology and radiological sciences. We know him as an individual that families call on in their darkest times for help with some really extensive psychiatric conditions. And tonight he'll be speaking about the early first break psychosis program that they have there at Vanderbilt. So I am going to leave you to this excellent presentation, which I have no doubt it will be. And please enjoy. Thank you, Dr. Heckers. It's all yours.
Thank you, Robin. Thank you, Don. Thank you, Tracy. It would be nice to see you all in person. And I very much hope that next year we can do our NAMI fall meeting that I attend every year in person. So I really hope we can do that.
Dr. I'm going to stop for 1 second and ask everybody to please mute their phones so that we are not getting any background noise other than your presentation. Thank you, everyone.
Thank you. Well, again, I really hope that next year it will be in person. It has been too long that we had to rely on Zoom. One of the advantages, however, of a Zoom meeting is that you get a very nice, crisp presentation of slides on your screen. So, of course, for all of those who will listen to this presentation as an audio file later on, you have to imagine those slides. So I will always try to explain what people see on the slides. So let me start sharing. And I hope that you can see the slides in the way that people want to see them as full screen. So I'm going to talk about coordinated specialty care. I will say a little bit about our program, but I will start with a more general introduction of what actually coordinated specialty care means. And this coordinated specialty care is designed to help a person in the early stages of psychosis. So I will start out first with kind of reviewing what that means, psychosis, and who the people are that I'm referring to. And then we'll focus on the team building that we have engaged in over the last couple of years, which is now considered really the gold standard for the best possible treatment for a person with a psychotic disorder. So most people, when they hear psychosis, think about hallucinations and delusions. This is what the vast majority of people think about when they hear that a person has experienced a first episode or first break of psychosis. It also comes with a disorganization of thought and behavior. And in a good number, not all, but in a good number of individuals who develop a psychotic disorder, it also comes with so-called negative symptoms. And they come in two different varieties: a lack of will or a lack of drive. The fancy word for that is avolition. And an inability to experience or express emotions, often referred to as flat affect. So those are the so-called domains of psychosis, and they can give rise to various diagnoses. Most people hear about the diagnosis of schizophrenia as the primary psychotic disorder, and they often are interested in figuring out whether the person who experiences hallucinations, delusions, disorganization, whether they have experienced a case of schizophrenia or whether it is something different. And we in the field of medicine refer to that as the differential diagnosis. What are the potential diagnoses that could capture the person's experience? So psychiatrists are often asked, if a person develops hallucinations and delusions, is it schizophrenia or something else? And one particular diagnosis that often gets confused with schizophrenia is bipolar disorder, particularly the type of bipolar disorder that comes with psychotic features. And lastly, when a young person develops psychosis, there's often a concern that it might be something different, that it might be a warning sign of a medical condition, of maybe the use of drugs or even the use of prescription medication that has given rise to psychotic symptoms. So we refer to that as secondary psychosis. And last but not least, because of all of these different experiences, the field of psychiatry has come up with all of these different labels. These are the different diagnoses that the DSM, the Diagnostic and Statistical Manual, has recognized as psychotic disorders. I've listed them here. So I'm just giving you that as background information. I'm not going to spend too much time to explain the differences, but all people who have experienced psychosis and their families who take care of a person with a psychotic disorder at some point will come across this list of different diagnoses. And again, schizophrenia being the one that most people worry about, schizophreniform disorder and schizoaffective disorder being very similar and related to that. But then there are also others, like a brief psychotic disorder or delusional disorder, which could be considered to be minor variants of schizophrenia spectrum disorders. All right. And lastly, what we need to do to really understand coordinated specialty care, we need to get a better sense of the course of a psychotic disorder. And a person does not get born with a psychotic disorder. A person develops a psychotic disorder at some point during their life. And most individuals who have a psychotic episode develop this in their late teenage years or in their early 20s. There is another wave of psychotic disorders that comes later in life, sometimes in the 40s and 50s, but the majority of individuals who develop a psychotic disorder present for the first time with their first episode in their late teenage years or in their early 20s. When the psychosis emerges, it is often a very significant change from their previous level of functioning and from their previous ability to relate to others, to the world, and to make sense of the reality around them. Because of these significant changes in the person's thinking, feeling, and behavior, this acute phase of the illness leads to an intervention. And the vast majority of individuals get presented to a mental health care provider, often in an inpatient setting. So that is the acute phase of a first episode. After that, there's invariably a remission. And after the remission, often a significant risk for relapses into further episodes, so a second, a third, and further episodes of psychosis. I want to highlight, before we go further in our review of the specialty care teams, that there is a significant opportunity for us to detect an emergence of psychosis before the first episode is presenting itself. And that is often referred to as the prodrome. The prodromal stage of psychosis can take several years. And before the prodrome, there is even a at-risk state where the symptoms might not even be apparent, but the person is at greater risk of developing a psychotic disorder. So one example would be a person who has a family member with a psychotic disorder. Simply knowing that there is another family member with a psychotic disorder increases the risk for the person to also develop a psychotic disorder. That's not different from many other medical conditions, whether that's hypertension or diabetes. Simply knowing that an illness runs in the family puts a person at greater risk, even if they have not developed any symptoms themselves. There are other at-risk states, stressors, the use of drugs. All of those life events can put a person at greater risk of developing a psychotic disorder. So there has been an increased effort in identifying those risk factors early on in life, with the hope that we could diagnose early and potentially even prevent. All right. And then there's one really important message I want to convey to the group, and I hope that the people on the call can see the slide, but for those who will later on listen to the audio file, I will just describe what this slide shows. It tries to show the likelihood for a person in the general population to develop a psychotic disorder, and how we can think about the different stages of the illness as the person develops the signs of psychosis and then gets diagnosed. You see at the bottom of this slide that there are 4 different groups of individuals. There are healthy individuals. They're indicated here in this with this person in white. And then there are individuals who develop a psychotic disorder. They're indicated here in a red color. And then in between those two, the ones who is healthy and the one who develops a psychotic disorder, There are those individuals who develop other psychiatric disorders, anxiety, depression, but not a psychotic disorder. And then there is a fourth group. Those are individuals who develop attenuated symptoms. They develop symptoms that look like psychosis, but have not really developed the full presentation of psychosis. And this slide shows that in a cohort of individuals who are at great risk, only 1/4, 25% approximately, will actually develop a psychotic disorder. Whereas the other 75%, although they are at risk, and they might even already have presented with subtle signs of psychosis, will never develop a psychotic disorder. And these psychotic disorders are the ones that are listed earlier in the slide. So that includes diagnoses like schizophrenia, schizoaffective disorder, delusional disorder, brief psychotic disorder. Only 1/4 of individuals who are at great risk of developing a psychotic disorder ultimately progress to such a disorder. And the other 75% either will have no symptoms in the long run, that's 14%, or they develop other psychiatric conditions like anxiety and depression, that's 50%, or they develop a attenuated form, a minor form that never really reaches the diagnostic criteria. So that's a very hopeful message, that even those individuals at great risk of developing a psychotic disorder often do not go on to develop the full-fledged disorders. So that's number one. And number two is that even in those who do develop the illness, even a person who meets all of the criteria for schizophrenia, there is not one predictable outcome. So a person who has met the criteria for schizophrenia clearly has developed delusions, hallucinations, disorganization, or the negative symptoms for a period of at least 6 months. And because of that, also has found it difficult to engage with the world, has not been able to go back to school, has not been able to stay at the previous job. So all of those criteria are met, but even with that significant effect of the illness, there is not one predictable outcome. And there is a long history going back almost 100 years to find out what actually happens to a person who develops schizophrenia. And the rule of the 3/3 is a rough estimate that there are 3 different groups: those who do well in the long run, those who need treatment and will suffer because of the illness, but will do okay with the treatment, and then a third group who, even with the best possible treatment, will have significant difficulties to function independently. There are several predictors that allow a person early on to be identified as a person with greater risk for a poor outcome or for a lower risk for poor outcome. Gender makes a difference. Women do better than men. The acute onset is often associated with a better outcome compared to, let's say, a chronic, slow evolution of the symptoms. And also having had a high level of functioning before the illness emerges is a good predictor for outcome. And because of all of this literature looking at only 1/4 of individuals developing a full-fledged psychotic disorder, although they all have been at risk, and even after the development of the illness, only having a subset of individuals struggling in the long run, we have developed these ideas of a critical period in the early stages of the illness. That means there is an opportunity, a window for us to intervene early. And if we catch that early window, if we can identify a person, not later on in the illness, but in the first 2 or 3 years, that there is a significant effect to bend the curve, to improve outcome in the long run. And this is really what I want to focus on for the rest of my talk. The idea that while psychotic disorders are serious mental health conditions, there's a very hopeful message that an early detection and early intervention allows us to substantially improve long-term outcome and functioning. And I just wanted to see from Dawn whether there are, at this point, any questions or whether there's anything in the chat, because I have a little break here. This is the background information. And now I will just focus a little bit more on coordinated specialty care.
We do not have any current questions. I have put it out to submit them through the chat, though.
All right, very good. Okay, so this is kind of the background information that you would be able to see in a review article, or this is what a medical student might learn about schizophrenia the first time that they hear about the illness. So now having learned a little bit more about how complex this actually is, that it's not straightforward, but can vary quite a bit between individuals, I wanted to review kind of this new literature, which is about 20 years old by now. It actually did not start in the United States. The idea to create teams of clinicians, so not just a therapist or a psychiatrist, but a whole team that is devoted to the care of individuals with psychosis, really came from Australia and from the Scandinavian countries in Europe, who have really embraced this team approach for a little bit longer than we have in the United States. But this paper that was published in 2016 in the American Journal of Psychiatry, you see here the title, Comprehensive versus Usual Community Care for First Episode Psychosis, 2-year outcomes from the NIMH RAISE early treatment program. That study really was the first definitive clinical trial to show that a team approach is superior to the traditional community care. And that means the care that you would typically expect in a community mental health center with a therapist that you might see once a month, and with a nurse practitioner or physician who you might see once a month or once a quarter or even less frequently. So that's referred to as the usual community care. There are several acronyms that people use. RAISE and NAVIGATE are some of those. They don't really matter for us. It's just something that you might hear about. And I've spelled out here what RAISE is actually referring to. This was a initiative that the National Institute of Mental Health funded for several years. And this study is the result of that significant effort from the NIMH to show for the first time in the United States that a team approach is superior to the standard care. And it turns out that after these studies have been conducted, that there were 4 ingredients that were identified to be important for coordinated specialty care. That there is a personalized medication management, meaning the person is not just given a medication without further evaluation of how the medication works. It really is a sophisticated management using typically a nurse practitioner or a psychiatrist to meet with the person regularly in the early stages, typically once a month. And that approach will then allow the person to be treated with the best possible medication management. So that's component number 1. Component number 2 is that the family of the individual who's developed a psychotic disorder participates in psychoeducation. So this is somewhat similar to what we are doing now, where the family gets educated about what actually is psychosis. What do all of those diagnoses mean? How do we think about the illness? And those are sessions that are quite helpful for the family to make sense of the changes that have occurred in the person with a psychotic disorder. And secondly, to find out what the appropriate response is for a family when a person has developed a psychotic disorder. So how to stay calm and neutral and supportive. So that's the second component. The third component is individual psychotherapy, which is focused on resilience, which is focused on the ability to strengthen the individual who has experienced psychosis, rather than looking at this as an illness, looking at this as a deficit, to identify in each individual what their individual strengths are and allow them to cope with the stress that comes with the experience of psychosis. And then the fourth component is the ability to return to a job or to engage again in educational pursuits, high school, college, or any other education. And that is often referred to as the SEE, supported employment and education. So the teams that have been built over the years that we've now also built at Vanderbilt, and there are several others in the state of Tennessee, have those four components. And what is the difference in the outcome when a person gets this kind of team treatment versus the usual care? So these are the two questions that people were asked who were in the study. The first question is, have you met with a person who's helping you to get a job in the community or furthering your education? And you can see here that the person who gets the specialty care, which is referred to as Navigate, that's the name of that specialty care team, you can see that they are much more likely to meet with a supported employment and education specialist. So, but twice as often have they been in the last 30 days been interacting with a specialist who helps them to either find a job or return to school. And on the right side, it is the question, have you had individual sessions with a mental health care provider who helps you work on your goals and look positively towards the future? You can see that the usual care, only 30 to 40% of individuals would say that they have actually met with a counselor. Whereas in a specialty care team, that is much higher in the beginning, of often 80%, and then drops to something in the 50% range over the course of 2 years. So you can see very easily that the exposure to those two clinicians, the Cs and the therapists, are substantially greater in a coordinated specialty care team. And then the outcomes. This is a somewhat complicated diagram, and I want you to focus only on the straight lines, not on the hatched lines. And you can see on the left side the changes in quality of life. QLS stands for quality of life scale. And on the right side, it is the clinical symptoms, the degree of psychosis. And the two lines, the one that has the orange dots and the one that has the green dots, that have straight lines, are the difference between the usual care. The usual care is the one in green versus the coordinated specialty care, which is the orange line. I can use my cursor here. Can you see my cursor? All right, so this line here, the orange line, the straight orange line, is the change in quality of life starting at the beginning of the trial and at the end of the trial after 2 years. You can see that there is a significant increase in quality of life rating for those individuals who have received the coordinated specialty care, compared to the group that's here also in the straight line in green that has received usual care. A really important difference that emerged in the study is that the only difference that was found in individuals in the early stages of the illness. But if we wait for the psychosis to run its course for more than 74 weeks, this is the separation here, so this is more than a year and a half, then those two treatments are much more similar and don't show the superior effect of the coordinated specialty care. So it means that we have to intervene early in the first year, year and a half, and then we see a substantially greater improvement in quality of life. On the right side, you see the improvement in clinical symptoms. So here, The score means if it goes down over the 2 years, it's an improvement because the score here shows the degree, the severity of psychosis. The higher the score, the more psychosis is present in the individual. And you can see that there is a decrease over the 2 years, and that a decrease is much more pronounced, a steeper slope in those individuals who receive the Navigate, the coordinated specialty care. All right. So that's the summary of where we are with the literature. So that's the summary of how to think about psychosis. And that's the summary of how we think about the research that has been done so far to compare coordinated specialty care with the standard care. And so that's the review. And I will now switch to kind of where we are with the team at Vanderbilt and describe the various roles. There are also several people on the call who actually serve in those roles. And it would be great if we could just have maybe a minute or two from those individuals to briefly share with the rest of the group what their role is on the team. So I see several of you there, but I will first kind of outline what the roles are, who are the team members, and then maybe we can get more of a conversation going between the various team members to describe how they contribute to the team. All right. All right. So we do have a website, although the website doesn't really describe the various roles in detail. But you can see at the bottom here the link. You can just enter VUMC, Vanderbilt University Medical Center, and early psychosis, and then you will find this. So the team is really focusing on 4 different goals. Most of the individuals that we take care of at Vanderbilt have already experienced a crisis. They have experienced a first episode of psychosis. So it's not that we have to think about, is the person developing a psychotic disorder? Are they still in the early so-called prodromal stages? The vast majority of individuals who come to us, to either the hospital or to our outpatient clinic, have already experienced at least one episode of psychosis. So the first goal really is that we help them in their acute crisis and stabilize them so that they can return home and can engage again in educational pursuits or seek a job and develop meaningful relationships with friends and with family members. So that's the first goal, to stabilize, to treat the psychosis, and then allow the person to return back to home. Then, once the person has been stabilized, we then offer the person to return to the clinic for outpatient treatment, which typically includes those 4 components that I just mentioned before. When they are engaged in the outpatient treatment, then they're also offered to meet with the supported employment and education specialist, the Cs, who focuses very much on that exploration of what is the person interested in, what have they done before, what kind of jobs or schools have they been interested in and would like to re-engage with. And then the whole team, of course, is very much focused on preventing any further crises, any further episodes of psychosis. And that often is measured by the likelihood for the person to require hospitalization again. So we try to prevent any further hospitalization after the first episode. So the team includes these 5 different positions. In addition to the 4 that I just mentioned, there's also a team leader who actually organizes regular weekly meetings. And that team leader originally was a social worker. Now it is a licensed professional counselor. And so these positions of team leaders are typically social workers who have skills not only in the domain of psychotherapy, but also in the domain of case management. And then the other two providers that you would see also in the typical community-based treatment that is not coordinated specialty care are the therapist and the medication provider. We have either psychologists or master PhD clinicians in the therapy role, and we have either physicians or nurse practitioners in the medication provider role. And then the last two positions are the supported employment and education specialist and the certified peer recovery specialist. So the certified peer recovery specialist is a person with lived experience, a person who helps the treatment team to build bridges between the person who experiences psychosis and the clinicians who want to engage the person in either therapy or medication management. So engagement is the major goal for the team. And engagement occurs at various stages of the illness. Of course, one is engaging the person to make decisions about treatment with medication. Another one is engagement of the patient so that they are interested in and willing to pursue either individual or group therapy. And particularly in the hospital setting, when the person is still experiencing an acute crisis, it is the important role of the team to plan for the discharge, to not only engage in medication treatment and psychotherapy, but also in returning home and engaging in work with the Cs for either employment or education. Okay, I'm just looking at the chat here. Okay, but those are not for me. All right, very good. All right. So, may I ask Kelly to say a couple of words about kind of the team in general, kind of how we work together. And Kelly Vance is our team leader. She's really organizing our weekly meetings and can tell us a little bit about, maybe you can just tell us how you actually became a member of the team, what you did before you became the team leader, and how you're working with all of us.
Sure. Like Dr. Hecker said, I'm Kelly. Master's level therapist now, working as our team lead, but formally came on with Vanderbilt about 3.5 years ago as the supported employment and education specialist. So I was in that role for a while before I graduated and was able to move into this role now. But as far as our team goes, we meet every week to talk about our list of designated clients, patients, whatever you want to call them, to discuss their goals, their desire for recovery, whatever that looks like. And we all coordinate together about how we can best serve them and helping them do those things. So we also talk throughout the week about different things that are going on with certain patients. It doesn't just have to be once a week, but we try to problem solve and determine what would be best for a person to help them get engaged and stay engaged in our clinic and reach whatever goals they have. What else?
That's very good, Kelly. How different is that, what you just described, that teamwork? How different is that from being a patient in the regular clinic, not just our clinic, but clinics really in various settings?
A typical clinic might be more of just one medication provider and one therapist working with a patient, but they typically aren't coordinating maybe as regularly, and they don't have the added support of an education specialist and a peer specialist on the team, or the family piece that we're starting.
The family psychoeducation. And we don't have another Cs on the call. So since you've worked as a Cs, maybe you can briefly tell the group, what does a Cs actually do? How do they interact with a person who has experienced psychosis?
They typically, it's a pretty easy sell. Our clients want to work with somebody to help them find a job and go to school because that's what everybody wants to do. They usually will meet with the client a few times, 2 or 3 times, to assess their interest, their experience, and talk about the things that they didn't like in their past jobs so that they don't have to go back to another job like that. And then they'll do literally whatever it takes to help them get the job, help them build the resume, do mock interviews, pick them up for work or pick them up for the interview, help them go shopping for professional clothing, whatever it is that's going to be helpful. That's what their job's going to be. They also don't have to meet at the hospital, which is great. So they can meet at Starbucks or a library because nobody really wants to be at the hospital. So that also makes it a lot easier for our clients to engage with the supported employment person.
Very good. Thank you. Thank you very much, Kelly. We have 2 physicians on the call who have been working in this particular team, the first episode team, Dr. Stovall, who has been with us for a good number of years, and Dr. Fall, who joined us more recently. Both of them are engaged in outpatient care, but also taking care of an individual during the acute crisis. And Dr. Stovall in particular also has an important role to play in our partial and in IOP programs. So he's really quite familiar with kind of all of the different services that Tracy mentioned at the beginning of our meeting that we offer. So Dr. Stovall, can I ask you, how does the team approach that we are talking about now, how does it differ from what you typically would do for a person in the clinic or in the hospital? How does this team effort really make your job as a psychiatrist different?
Certainly for most patients in the clinic, the work is me and the patient, and typically it's around medication. So there's really not a collaborative approach. There's not other people's opinion. There's not other people's expertise. So it's a much narrower focus of the treatment, which for some people is plenty. But for individuals we're talking about here, it really may not include the psychotherapy. It certainly doesn't include the peer support and really never includes that focus on recovery that can come from working with the Cs. So I think it's much more symptom-based as opposed to this broader collaborative care, which really is much more recovery-based.
Yeah. Well, thank you. And Dr. Fall, you are spending a lot of your time on the inpatient unit interacting with a person, typically a young person who's never been in a psychiatric hospital before, who has to make sense of all of these unusual experiences. And you have now worked in the setting with the help also of some of these team members who are not just available after the hospitalization, but can even be participating in the care of an individual when they're still in the acute crisis, and particularly meeting with families and educating them about what it means to experience psychosis. So just in your experience, how does that team approach during the acute crisis already have an impact on the person's ability to engage in treatment?
Yeah, I would say that it has a pretty large impact. Mostly just getting to know the individual and their family helps us to have a better sense of what the level of needs are from not only psychiatric symptom standpoint, but education standpoint, family dynamic standpoint, and just already getting a sense of their recovery. So it helps us out to then be able to continue their care going forward in the outpatient setting. But it really helps the individual and their family to know, to already get to know us as their treatment team and to have some level of gaining trust in us. And it's just that much easier to then continue working with some of the same providers once they transition into the clinic.
Yeah. I think you just mentioned a really important word. We talked about engagement so far, but you also talked about trust. One of the real challenges in helping a person who's developed a psychotic disorder is that it is so disorienting, it is so confusing that they find it very difficult to trust another person, particularly one who comes, into the hospital, with the typical expectation that they just need to be told what to do, and they just have to listen to the doctor. That is often not possible for a person who has developed paranoia or hears voices and finds it very difficult to trust other people around them. So having the ability to then engage with the whole team and also educate the family and the individual who develops psychosis in that way is often quite helpful, and allows the person to develop this trust in the alliance. And then we have two of our psychologists, our therapists on this call. So Dr. Brennan and Dr. Musa Tux, both of them are very important members of the team. And both of them have also helped us, even on the inpatient unit during the acute crisis, to start psychotherapy work. So it's not just something that happens afterwards, after the person has been treated with medication. We try to engage even in the first couple of days in the hospital to build those connections and to help the person on that road towards recovery. So if you could maybe share a little bit about this, Dr. Brennan, maybe you can go first, and kind of how do you think about recovery as the goal of therapies? Is that different from what we typically do in psychotherapy? Is our approach to psychosis different now if it's focused on recovery?
Yeah, one of the shifts that we've seen, and it really was born out of this work on sort of applying psychotherapy to people with psychosis, was the idea of looking past the symptoms, because we can get into oftentimes very much of a power struggle with individuals over when we're just focused on symptoms, but really focusing in on what's getting in the way of somebody moving toward the life that they want. And over the years, particularly as we've been looking at sort of CBT for psychosis and ultimately developing other versions of CBT for psychosis, which has been around actually for 30 years now. But this idea of using that to help people just move back toward their lives. And it's wonderful because it allows us to collaborate with the individual, where they're the expert in their own lives and we're experts in how many people have moved forward in their life. And so it's a wonderful collaboration in that way, but not necessarily focusing on identifying or saying that this is a symptom, but focusing on the things that are distressing us so we can move forward. Things like when we worry, it makes us more stressed, but that's very normal. We all worry. Or things that sort of bother us and get into our mind and sort of distract us. We all have those experiences, whether they're voices or loud thoughts. We can sort of help to sort of correct those lessons we've learned about life, so it makes it easier to move forward. And so that's really the focus in the psychotherapy approach. And it allows us to collaborate really well with Cs and the medication providers and the peer specialist as sort of one really cool team. So it's wonderful.
Just to follow up, one more question, Dr. Brennan, is that focus on recovery new? Is that something that we've always kind of focused on, or have we realized more recently that psychotherapy should really focus on that first and foremost?
So if you look back at really some older writings, even going all the way back to 1976, when Aaron Beck wrote one of his first books, Cognitive Therapy, the Emotional Disorders, he essentially writes about recovery, that individuals, he calls them patients, but patients can draw on their own problem-solving apparatus. And then I think there was ways that we got very muddy in sort of saying, well, here's a symptom that we have to get rid of. And so I think in recent time, many of the people who've developed treatments, we've all really focused on really what does the individual want, and how do we help that person move toward the life that they want. And as long as those symptoms don't get in the way, we don't necessarily have to create this sort of problem list that we knock out one after another. We don't have to be like symptom hunters. we can really focus on what is actually right now blocking your movement toward recovery. And so that's really, I think we've sort of come back to a much more, back to our roots. We sort of like swung the pendulum one way and come back the other way.
Very good. Thank you. And Dr. Musa-Tux, if I may ask you, so most people have kind of their own ideas of what psychotherapy looks like and what it feels like. So if we feel that psychotherapy is an important component in the treatment, is that something that has to go on forever? Is that something that people need to do for the rest of their lives? Do they have to do it every week? Give us a sense as a therapist, kind of, as you think about what your contribution is to the coordinated specialty care, kind of how do you start out with a person? And is that something that has to go on forever? Is that something that has to occur every week? Or can you tailor that to the individual and it can actually be quite variable?
Yeah, that's a great question. I think a core feature of coordinated specialty care is that it's customizable to the individual. So they're getting access to all these different services and utilizing the ones that are most useful for their recovery journey. And I think of therapy in a very similar way. So typically I like to start by seeing individuals weekly, but from my perspective and very much a CBT, cognitive behavioral therapy perspective, treatment is time limited. It's not meant to be forever. The goal is to really get the person to reach the goals that they want, get them to the point of recovery that they're interested in, whether that be by building certain skills that they might need help with, learning tools to manage symptoms, or even just working on building relationships, getting all those wins, and then really them becoming their own therapist and being able to take that toolkit out into the real world and apply it to new problems that might come up. And use it along the way. And of course, if the person is ever interested in coming back for therapy, maybe a new problem arises or some set of circumstances have made it difficult for them to apply the skills that they've learned, they can always come back for a booster session or come back for a full session of therapy to address those new concerns. But yeah, I would say in general, I don't see it as something that the person is in forever. And really, we want them to become their own therapist.
Thank you. Very, very helpful. Maybe one more question, going back to Kelly. So how big is the team? How many people really are covered by our coordinated specialty care team? And how long does a person really work with the team before they go on, as Dr. Musa-Tux just mentioned, with their own lives and pursue their own goals? Can you give us a sense of kind of how do we go about building the team? How big is the team and how long do people stay with the team?
The team currently is at 18 people. We have the capacity for 30. So we're still building in that sense, but we also have a lot where they have a 2-year period to be with us, from starting with the Navigate program to transitioning off of our team. But we see people come and go. So I'm not quite sure what the average stay on our team would be, but it probably is not quite 2 years. It's probably a little bit shorter than that in my experience. But some people do the whole 2 years and they still kind of stick around. So we still see them a lot and hear from them a lot. And some people move or they go on to other opportunities, but around 2 years is the goal of having people on the team.
Thank you. And maybe, Dr. Stover, can I ask you, there's one concept that has been brought up, and the two of us have talked about this over the years. I finished my slides with a slide on engagement, to actually engage the individual who's developed psychosis, to help with treatment planning, to help with what medication, or is medication necessary at all. So this concept of shared decision-making, that the person who is experiencing psychosis needs to be treated as a partner in that decision, rather than just simply as the person who's being told to engage in treatment. In your experience as a psychiatrist over the years, how has that kind of shaped your practice in your role as a psychiatrist? This concept of shared decision-making and seeing the person as a partner in the treatment.
It's definitely something that's evolved throughout my several years of being a psychiatrist, and as things have shifted from a much more paternalistic, doctor knows, doctor prescribes approach to a much more collaborative approach. I think Dr. Brennan mentioned that really the focus now that I try to bring, even talk about medications, is so what's your goal, what you're interested in, what are your targets, and let's try to identify things that may get in the way of you going back to school, of you working, whatever it might be. And then I can say, well, from my experience, this is what I have to offer that I think in general can help somebody who's run into those obstacles or wants to meet those goals. And medication can play a role in that. I can talk about that. I can give an individual options, talk about the pros and cons. But again, it's me bringing my expertise to their expertise. Their expertise is, this is what I want to accomplish. And together we figure out what are the obstacles in that. So again, a much more collaborative approach and open discussion that frankly doesn't always involve medication. You know, I have any number of patients who I see who don't have chosen not to take medication, who have stopped medication. And my approach is always, in effect, to leave the door open. I may continue to talk about medication if I think that would be helpful, but it's not necessary for the ongoing relationship or even for the ongoing treatment, though clearly there are times when it's crucial. Yeah.
So maybe we can finish by summarizing this in the way that the person who experiences psychosis is the expert to decide what goals to pursue. That we might be experts to review the potential treatments and to review with a person what the options are: psychotherapy, medication, psychoeducation, getting help to find a job, getting help to go back to school, that we can help with that. And we might be experts in advising the person. But even a person with severe psychosis at the end always remains the expert for their own goals and what they would like to achieve in life. And that there's not a prescription for that, that there's not a direction that we need to provide for the person. And if everything works well, then those two experts can meet and figure out what is the best course. So, all right. We have reached kind of the 1 hour mark, and we typically kind of wrap it up after an hour, but we are here if there are other questions, and if people want to ask me or any of the other team members that you just met, please go ahead and either send it through the chat, or maybe people can also unmute themselves and just speak.
I've got a question in the chat for you, Dr. Hackers.
Okay.
Person says, I really appreciate the collaborative approach being discussed. I wonder how you manage situations when a person's symptoms are influencing their goals.
Yeah. Well, that of course is often the case. And the real challenge is when the person has given up on having any goals. It's not so much a problem if people have goals that are unreasonable. Quite honestly, most of us have unreasonable goals at some point in our lives. And that in and of itself is not the problem. The most difficult situation for us is if the person has given up on life. I'm not talking about depression. I'm not talking about ending life. That's not what I'm talking about. A lack of interest in living, lack of drive, where the person is not really able to even articulate a goal, let's say finding a job, finding friends, going back to school. And that is for us in the treatment of psychosis, the biggest challenge. So it's not a disagreement on the goals, but it's a lack of goals altogether. So what I use often as a metaphor is, you are driving a car and the car gets off the road and is stuck in a ditch. We in psychiatry can help you restart the engine. We can get it out of the ditch and we can get it started again so that the engine is running. But that's all we can do. You need to decide where to go. We cannot give you the direction. We cannot tell you once you've been moved out of the acute crisis, when the psychosis has abated and the person could go on, we cannot make that decision for the person. So that's why the treatment of the so-called negative symptoms, the avolition, the flat affect, the lack of drive is quite challenging. And that requires a very sophisticated approach that includes sometimes very significant medication, like clozapine, which is a very effective medication, but also requires very intense medical management, including blood draws and making sure that there are not serious side effects. It often requires very substantial medical intervention and really good psychotherapy. So we really are very fortunate at Vanderbilt to have outstanding therapists, and we have many, many meetings and conversations to fine-tune our approaches. And it sometimes takes a year or two for the person to find again that direction and find again kind of the goals. So I hope that that addresses this question. This is, of all of the challenges that we have, the most significant one. Even with a good team, we cannot be successful if the person does not find life worth living for and has given up on goals.
Thank you, Dr. Eckers. Do we have any more questions, either in the chat or if you want to just unmute?
Can you hear me?
Yes, we can hear you, Rocky.
Okay, thank you for presenting this program. It's been very informative. As you probably know, and Robin knows, I have a friend who has had some great amount of difficulty, and it's a long story, and it takes a long while to explain to someone my knowledge of the situation. But she has been in Vanderbilt several times, and the program that is being presented here seems to me would be ideal for her. Now, I wasn't able to really communicate with anyone at Vanderbilt, even though when we use the word family, most people think genetic family. But when there's no longer a genetic family, then a person does develop a family. And that family is critical to their hopeful wellness. And also that family is in extreme trauma themselves because they have firsthand experience with the danger involved and with the trauma involved. So, and I'm in that category, as perhaps you and Robin know. But I've always, well, I don't want to go on and on here, but anyway, I would like perhaps at some point to contact someone at Vanderbilt and discuss further the situation that I'm dealing with. And it's devastating me. I'm very traumatized by it. But there's danger involved. And so if possible, I would like to perhaps make an appointment with someone and take a little bit of time and present the circumstances that I'm dealing with.
Yes, I'm offering that you can contact me, and I'm more than happy to talk with you. We can meet and we can review kind of where we are currently and what we can offer you.
Well, would you be comfortable with me sharing your email address with Rocky, Dr. Eckers?
Yes, no problem.
Yes. After the meeting, Rocky, I will get you. I will get you his email address. Okay.
Very, very much.
But what you mentioned is, we have not talked very much about the family psychoeducation. It's not so much the education itself, it's also how to help the family, whether that's the genetic family or let's call it acquired family, a group of friends, a group of people that care about the person with psychosis. It is, as you say, devastating. Sometimes there are risks involved, yes. But even if there are no risks involved, it is often very, very challenging to remain hopeful, to remain optimistic. And that has turned out to be quite challenging.
It's also very, very difficult to remain even patient, even patient with the circumstances.
That's right. You mean patient meaning calm.
Calm, yeah.
That's right. Yeah. In fact, that's what I tell the families. The number one challenge is to remain supportive, but also calm and neutral. Because psychosis is a different view of reality, a different view of the world. And if you are a friend, a family member, a loved one who cares about a person with psychosis, it is extremely difficult not to be pulled into that world of the person with psychosis, because that person wants to validate their own experiences, and they want other people around them to confirm how they see the world, which might not be possible. And so it is extremely difficult to be supportive and empathetic, but at the same time neutral. That is the challenge.
Thank you. Thank you.
Yeah.
Do you have any other questions? Got a quiet group tonight.
I have a question.
Sure, Jennifer.
What is the easiest way to communicate with someone when they're in their crisis mode without the potential of being dragged under?
Without the potential to be dragged under, did I hear you right?
Yes.
Yeah.
Yeah, dragged under by the psychosis, by the paranoia, by the hallucinations. Is that what you are referring to?
Yes.
Yeah. So the question really is how can we reach the person? How can we really build that relationship, that trusting relationship to a person who is dragged into or under the psychosis? It is somewhat similar to the statement that I just mentioned when it comes to how a family needs to respond to that. I have found it invariably to be true that a person, even in the severe stage of acute psychosis, wants to make sense of the world around them. Their primary goal is to figure out what the heck is going on, because they experience the world in a way that's frightening and scary. And they want nothing more than finding out how to make sense of it. And that is often the common ground. Now, I'm not saying that it's easy to explain it, but it's the desire, the strong desire to make sense of the world. Even if the world is scary and the person feels that nobody can be trusted, it is still that hope that they can find a way to make sense of the voices, of the paranoia, of the anxiety. And that's where I start. I try to really build that bridge with that simple statement: let's find out how to make sense of those experiences. And then also help with medication to take the edge off, to make people more comfortable in their own body. Because that's what people often don't realize, that when psychosis comes, it's not just in the person's mind. The person actually finds it very difficult to even relate to their own body. And so how to move, how to feel comfortable, how not to have constant panic attacks. So it's really a combination of things that needs to be done for the person to feel more comfortable, so that the world is not so frightening around them. So I find that the best possible way to reach the person, even if they are torn under psychosis.
And if I could add to that a little bit, and also to what this would be relevant for Rocky, what you were talking about. While we don't want to necessarily agree with some of the experiences the person is having, like you don't want to go farther down like a delusional thought than you need to, you can at least validate the emotions and what's frightening, the anxiety. You can validate that piece of things while not having to go down like kind of the rabbit hole and getting stuck under all of the psychosis. You can at least validate the experience of what's happening without having to go down that path with them, if that makes sense.
That makes a lot of sense.
I think, you know, and piggybacking on what Kelly's saying, I think she makes a really good point, because oftentimes I find that people want to be heard, and in that sense, they're helping to make sense of it. And we can get wrapped up in what they're saying. But when we validate the emotion and we say, have I got that right? They get that sense of somebody's listening to me, right? And I have to say, I'm a little biased because my colleagues on this call, I find like whenever I've heard what they do, it's the way that they always lead, is that idea of listening and checking that they've got it right. And you see somebody relax, even if you haven't agreed with a word that they've said, but you really say, this is really upsetting you, am I right? They finally have that moment where they feel like they're being heard, in this moment where they feel so separate from the rest of the world that's around them, which is a really scary way to be. You know, we're not designed as humans, we're pack animals as humans. And so when we're separated from the pack, it's a really scary situation to be in. And so it's a nice thing to give.
All right. I really appreciate all of the team members who took an extra hour or even more of their time in the evening to come together and kind of tell the story, because I can show you a couple of slides, I can show you a couple of, you know, graphs, but what you just heard from Kelly as our team lead, and Dr. Stovall and Dr. Fall as our psychiatrist, and Dr. Brennan and Dr. Musa Tooks as our psychologist. And of course, Kelly playing two roles, first as the team manager and also as the previous supported employment education specialist. It really is a team effort, and I'm very, very glad that we were able to present it as a team rather than just one person. In fact, in all of my time at Vanderbilt, having done these fall presentations to NAMI, that's actually a first, that we do this as a team, and I hope we do that again in the future.
We appreciate that. I do have one more question, Dr. Ecker's in the chat. Is there a way to explain the voices they hear? For example, I know someone who hears voices of people he knows, so he feels it is so real, but trying to explain that is difficult.
Yeah. So at the core, really, it is what needs to be explained. So when the person asks, is there a way to explain the voices? So the first thing is to actually recognize when a person hears a voice that we refer to as a hallucination. That means a voice in the person's mind that we cannot really connect to anything that's happening in the world, meaning there's not another person that we can identify who is the origin of those voices. The first thing to recognize is that that feels like and is experienced like a voice. It's not any different from the voice that you just hear me saying those words. It's a genuine experience. It's a perceptual experience that comes with the full power and impact of hearing a voice from another person. So that's really important to first identify and clarify, because hearing a voice can mean many different things. You would be surprised what you learn when you actually ask the person to describe the details of a voice. What does it sound like? How loud is it? Where does it come from? Who does it remind you of? So it's really important for anybody who's trying to explain voices to understand first what that feels like. And a good number of experiences turn out to be not voices at all, but experiences that are more like thoughts that are in the person's mind, memories that are being replayed. So that's number one. And then number two is that those experiences, those voices are often related to events in the person's life. So when this person says that the voices resemble the voices of people that they know, that's quite common. In fact, most voices that a person recognizes that we consider to be hallucinations are the voices of people in the person's life. So that could be a family member, it could be a friend, or it could be a person that they are afraid of. So it's really important to understand first the details of those experiences. Tell me, Dr. Brennan, once you've identified that, once you identify what the experience of a voice is to a person, what do you do? Do you explain to the person what a voice is, or do you leave it as an experience without a further explanation?
I think it's, I follow what we've been talking about. It really depends on what the individual's asking. So there are some people who come in and go, what is this thing? I don't know if it's a part of my mind or if it's something out in the world. That person, we may have a conversation of, well, here's a whole bunch of different theories as to what it is. If a person's really not interested in that, I'd be more focused on what belief do they have about that voice, right? If they believe that the voice comes and goes as it pleases, I might really focus on that piece of it, and helping them recognize that they actually have a lot more control over it than they think. Or if they believe that the voices are credible, telling them the truth, then I might help them to start like really reevaluating that idea. The idea of whether the voices are a part of their mind or not a part of their mind, that's a belief that actually has like the least impact on a person's functioning, but it oftentimes can elicit a really strong sort of power struggle and disconnection. And so I would really just focus in on sort of what they sense they make of it and see if we can come up with a more functional way that allows them to sort of move away from being so focused on the voice, so that they can live their life.
So thank you. So in a nutshell, explanation doesn't mean that we tell the person what the real world sounds like or looks like, that we as the treaters have a sense of reality that is the right one, and the person has some kind of a distorted sense of reality, which is what psychosis is supposed to be, an impaired reality testing. We are not really engaging in that power struggle, as Dr. Brennan calls this, where we want to convince the other person what is true and what is not true. We start out first with an understanding what exactly does this experience feel like, how often does it occur, how can the person develop coping mechanisms and abilities to actually prevent those, or if they cannot be prevented, find ways to actually soften the psychological and emotional impact. So the explanation is not about establishing first the right view of the world, but more importantly, to engage the person to make sense of this and find ways to live with those experiences.
And the person who asked the question thanked you. So thank you, Dr. Heckers. We're coming up on 8 o'clock. If there are, that was the last question, but I want to thank Dr. Heckers and his team for coming and spending time with us tonight. They're good friends of NAMI, as Dr. Heckers has said in the past, and tonight we're hoping to do this in person next year. Definitely we'll see Dr. Heckers and his team at the walk in person again.
Definitely.
But I want to thank you all. I want to thank Vanderbilt Behavioral Health and Tracy Glasgow for working with myself and Robin to set these education sessions up. I want to thank you all for coming tonight. This shows that the Vanderbilt and professionals in our community are invested in what we at NAMI are doing, talking about it and educating people. So I want to thank all of you.